All right, well, I'm going to go ahead and officially get us started. So good morning, everyone. Thanks for joining. I know we still have some folks filtering in, so we'll do some housekeeping up front and get everybody in from the waiting room. So if you're newer to this group, my name is Alicia Watley. I'm with Kentucky Youth Advocates, and we are the backbone organization for the Oral Health Coalition. So we provide the staff support and put on all the meetings and events. So today we have our spring meeting. We're happy to see everyone again, some new faces, some folks who we engage with regularly. And so just to get us started, I want to go through a little bit of housekeeping, some things to remember. If you've been to a KOHC virtual meeting before, you know that as an active KOHC member, you have access to CEU credits for the meeting. For dentists and for dental hygienists. So we ask if you all, anybody who's here today wants to introduce themselves in the chat, please feel free to do that. If you are seeking a CEU for the meeting, you should have indicated that on your registration, but we also would love to have you put that in the chat along with your name. So you can just put your name and what kind of CEU you're seeking, so dental or hygiene. And then that way we will have for our records, and we use the Zoom tracking to tell us who's here for the whole meeting and to record all of the chat. So please put that in there if you're seeking CEUs. If you have questions about that process, Linda Stettenbens, you can find her name in the list of participants. She's one of our co-hosts. She is kind of my right-hand lady in running the coalition, and she can help with anything related to CEUs. So if you have any questions, let us know. The other thing I want to point out here at the beginning that sometimes folks do on Zoom and sometimes they don't, but I want to make sure everyone's aware, is that we have turned on the Q&A function for this meeting. So you should have two different options on the bottom of your screen, a chat and also a Q&A. The chat we would encourage folks to use to, if you have reflections, if you want to share something, please, you can do that throughout. But we're going to be using the Q&A feature if you have a question that you want somebody to try to answer aloud for the group. We do have a larger group with us today, so we will be just trying to keep track of questions, and we're going to have a panel discussion a little bit later that we will open it up to questions, and that's going to help us on our end kind of keep track of which ones we've addressed. We can sort them out, things like that. So please use that feature throughout, and we'll try to keep track of that. And if you do have a question, please let me know. So myself, my name says KY Youth on your screen probably. Linda, and then Sasa is also staff support. So if you have a specific question and want to direct message somebody, those are the people to reach out to during the call. Okay, I think that might be most of our housekeeping. I will say that we are recording the call. So if you have any questions or issues with that, reach out to one of us, but just wanted to give that heads up. And with that, I want to first, before we get into the agenda of the day, thank our sponsor for this meeting, which is CareQuest Institute for Oral Health. We do have opportunities for folks to sponsor any meetings or events that KOHC puts on. There is a page about that on our website. So if you want to check that out, if you're interested in being a sponsor on a future meeting, please let us know. We have lots of different choices for that. And with that, I'm going to move us into a brief overview of what the agenda will look like today, what you can expect, and what items we want to cover. So first, we're going to, like I said, do introductions in the chat. Please let us know that you're here. And then we're going to go into a legislative update. I'm going to give some updates on what's been going on in the last 48 hours. I think we've had more changes than we've had in the last 2 months, but lots to talk about there. So I want to give updates on what happened with all of KOHC's priorities. The legislative session is not quite over, but we're close. And then maybe what to expect next. And then we'll talk a little bit about some of the coalition projects and events that are coming up later in the year. We'll leave some space for members to give updates if anybody wants to share about what you're doing around the state. And then we're going to have the bulk of our time spent on a panel discussion talking about opportunities to increasing access to care here in Kentucky. So we're really excited about that. Hopefully we'll have a really rich discussion there. So that's the agenda for today. And I'm going to go ahead and move us straight into our first section, which is legislative updates with me, Alicia. And so a few things that are maybe a refresher. I know a lot of folks in this space are following along with what's going on in the legislature, and some are not. So I just want to give sort of a grounding moment of where we are, what's coming next. The 2024 General Assembly was 60 working days, started in January. And it's a state budget session. So this is what those of us who work in the legislature call a long session. So it's every other year. They work for 60 days and they work on a 2-year state budget. So there's just a lot going on, a lot of things to be considered. And so we've completed 58 of those 60 days. We are very close to being done. Today is the first day of the veto period, which means that the legislators are home for the next 10 days or so. And this is the time where they've passed a lot of bills, sent them to the governor's desk, and he has the chance to sign those or veto. So we're kind of in the down period for the next 10 days. And then they'll come back for 2 more days in the middle of April to kind of finish it out. So sine die, which means the last day is on April 15th this year. So that will be the final gavel. Nothing else can change after that point in this session. And just kind of some context for those who are following along or maybe aren't following as closely. There was just a lot of volume of content that happened this session. A lot of things went on. Over 1,200 bills were filed, which is a lot because if we think about each of those bills being a new potential law, that's 1,200 potential laws that they were considering in Kentucky. So a lot to consider, and a lot that impacts oral health in different ways. So I want to kind of go through some of the specifics of what we saw this session, and remind us what are the 4 policy priorities that were voted on by this coalition in December and that we prioritized throughout the session. So the first one of those was to protect community water fluoridation. So we're going to get into the specifics of that in just a moment. And if folks have reflections or stories about other states or their work to share, we can do that. The second was to increase the state investment in the Medicaid budget to support rate increases for dental providers. The third was to protect the current services that are covered by the Medicaid program. And the fourth was to reduce youth initiation of tobacco and nicotine products, which we know can be lifelong addiction and also have detrimental effects on oral health. So those were our 4 priorities identified. And I'm going to just go through each one of these, kind of share what we've done, what's been happening on the legislative side, where they ended up. And then if folks have questions, you can feel free to come off mute and share as well. So the first one, protecting community water fluoridation, you all heard a little bit of a teaser at the beginning of meeting about this. We did see a bill filed, House Bill 141 from Representative Hart. The content of this bill is to allow local entities to opt out of fluoridating their community water supply. So in Kentucky right now, we do have a state law that says all of the public water supplies should be fluoridating to the optimal level. And this would just allow folks to opt out of that. We've seen this bill filed for, a number of years in a row now. We see this every year. And this year it did get a little bit of momentum at the beginning. So we saw a lot of advocates coming out in favor of it at the very beginning, and they were able to get it assigned and passed through the House State Government Committee. It did receive 2 readings on the House floor. And as a reminder there, bills have to get 2 readings, and then on the 3rd reading is when they can get passed out of that chamber. So the House could have voted on this. It did not. It got kind of stuck at that point. And so some of the work that KOHC, I know KDA was very involved, and several other partners did throughout the session was to just get folks kind of mobilized around this issue. And we did things like sending letters to the committee members, to House members. We had, action alerts that went out encouraging people around the state to call and oppose this bill. We had some of our members up there testifying in Frankfurt and talking about the bill. I know lots of people got outreach about media interviews. Dr. Robertson was just mentioning how much media attention this issue got this year. So ultimately, there are 2 more working days in April of session. We don't expect that would pass through the House in those last 2 days, but it did get a little bit farther this year than in previous years. So we're still definitely kind of on, alert about what that could look like in the future, and continued advocacy is needed about the importance of water fluoridation and how strong the system is here in Kentucky and how we want to keep that in place. So I'm going to pause and see, does anyone have questions about the outcome of this? What happened? Anyone want to share anything that they did throughout the session on this one?
Alicia, it's Julie McKee. I'd like to, if you don't mind, correct you a little bit, just because we're going to have to use the same phrases in the future.
Sure.
Is we wanted to vote it to keep it in place. The bill, as it's written, fluoridation can be kept in place. It has
Right.
to be voted out locally.
Right.
So
Yeah,
just
they can
want
opt
to,
out. Yeah.
yeah, they opt out. Now, we all know it's an anti-fluoridation bill, but we have to work within the framework given to us by the bill and message that way. Thank you.
Thank you, Dr. McKee. And Dr. Robertson, did you want to share?
Yeah, I just wanted to let everybody know that the KOHC was very vital in everything that happened with us fighting this bill this year, and everybody should be proud of the efforts and pat themselves on the back and support Alicia. Um, and I want to remind you, as Alicia said, this is going to come back, and now we kind of know the tack they're going to take. What was different this time was the addition of the local choice. Um, and that got a lot of play because they have figured out that just going in screaming anti-fluoride is not going to get it through. So they're looking for other pathways. And what Julie said was correct, because in the committee hearing, for those of you that didn't hear it, it was presented as a community choice bill, and then there were 6 people that testified in favor of it. 5 of the 6 railed on fluoride. The only person that talked about it being a community choice bill was the sponsor. So it is what it is, and it did get a whole lot of attention. And our lobbyist now calls me Captain Fluoride because I've been on the TV talking about this so much. But this is not done. This is going to be an annual event, and there was a lot of effort that went into this, and we were caught. I don't want to say we were caught off guard because we knew it was coming, but this moved very fast this year. And we're going to have to make sure that we are organized ahead of time so we don't have to go through the same thing at the last minute that we went through this time. And that's probably the most important thing about this, is just making sure that next year we're prepared, because they will be back.
Yep. I appreciate that, Dr. Robertson. We certainly are looking ahead to what's next with this issue. And like some folks shared earlier, it's trending around the country. It really in both directions. There's some folks that are removing it, some folks that are adding it back in. So we're trying to keep an eye on some of those national trends as well to see what might be coming to Kentucky. Anybody else have anything to share on this one or questions?
Hi, Alicia. This is Emily Beauregard with
Hey,
Kentucky
Emily.
Voices for Health. And I just wanted to add on, I do think that the education that KOHC and KDA put together was really helpful for legislators. Something that I took away, in addition to what Dr. Robertson mentioned already about the committee and the testimony, is that another tactic is assigning it to committees where it doesn't belong. And we typically think about doing education with members of health services, or thinking about the particular legislators that are going to be our champions. But I think at this point, when someone wants a bill to move and they know where their roadblocks are, they're going to be putting it into a committee that it is going to have a better chance in. And I think that's exactly why it moved so quickly this year. So the education with, a wider range of legislators over the interim, I think will be really helpful.
Yeah, thank you for adding that, Emily, and thank you. I know that KVH really got involved in the fight this year on this effort, so we really appreciate you all backing this and bringing some partners to the table that are not traditionally in the oral health space, which I think is important too, to show that this has a much broader impact than just our dentists and hygienists that are, yelling at the top of their lungs about this issue. We had a lot of other groups get on board with this, so we appreciate you all helping us bring some folks into the conversation. Anyone else questions or comments about this one?
Alicia, I want everybody to understand that what ultimately happened to the bill, my understanding, and Julie might want to comment on this, is that when it was assigned to rules, what hung it up was that when this was filed in state government, it was filed as a zero fiscal impact bill. And obviously, the realization was that if this went to fruition and communities made the decision to remove the fluoride, this would have a massive impact on Medicaid and other factors. So there was a huge potential fiscal impact. They're going to address that, and they're going to find a way to answer that. And I think one of the tacks that we need to look at is they kept repeating the fact that this is a non-funded state mandate. And Julie has talked a lot about this is not a huge expense, but maybe one of the things that we need to push for is for this to become a funded state mandate and remove that argument and take the money part out of it. I think that would be a good thing for us to start promoting and working together on.
Mm-hmm. Yeah, I think that's a good point. We were able to get some numbers from the Department for Medicaid and just how costly it could be removing just 10% of our population losing fluoridation could cost up to $20 million a year in Medicaid spending. And that's just 10% of the population. So, multiply that out per year on how much it could cost the Medicaid program. So it is a pretty big impact. And so I appreciate you bringing that up. And as I mentioned earlier, we're about to finish a budget session, and that only happens every 2 years. So there will be, some time for us to think about if there is a budget ask in the future to support the fluoridation program. It won't be next year, but possibly the year after that. So thank you yes, Dr. McKee, I see you have your hand up.
Did Dr. Robertson have one more thing?
Oh.
Okay. I also want to share with you all that we are finishing up a bit of a grant. Oh my gosh, I don't have earrings in, I have to leave now. A bit of a grant that we are funding the replacement or adding of fluoride equipment to our smaller water systems. That was one of the things we kept hearing, we can't afford it, blah, 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 blah. And we're like, you know what? We got a grant. Let's spend the money on you all to see what you need. And we're not redoing all systems. It's like, what's going to get you to where you're comfortable and feel like you've got a really, really good, robust system. And we worked with UK to do that, and we're wrapping that up. So when a system says, well, our equipment is aged and we can no longer do it, yeah, they can, because we have pimped them out.
Thank you for adding that. Appreciate that. And I'd love to hear about more opportunities for those smaller systems. Dan Brody, I see a hand up from you as well.
Yes, I have a question. What's the
Sure.
governor's position on this? And is there enough, for those of you that are in the know, is there enough votes to override a veto if would it not have to go to the governor's desk?
Well, I can't speak for the governor. I have not heard him specifically speak on this issue. I don't know if anybody else has heard any public statements from the governor's office on this. I personally have not. But luckily this year we don't have to know the answer to that question, because I don't think it's going to get to the point where he would have the opportunity to veto it. I don't think it's going to get any farther in the legislature. So it has to pass both chambers, right? The House and the Senate, and then go to.
Yeah. I'm thinking in the future is what
right.
Yeah.
I can't speak for the governor. I'm not aware if he has a public position on this. If anybody has any more information on that, please share.
Oh, overrides are very easy these days in both chambers with the super majority. So, if that's the will of the chambers, that will happen.
Absolutely. But it's a good question to ask, because if we see this continue to move farther each year, we need to kind of know where different offices are on the issue. So appreciate that.
Yeah. On that note, though, Julie, I think it'd be fair to note that this is not in any way a bipartisan issue. This is just kind of people are all over the place on this in the legislature. So if it got to that point where something did pass and the governor were to veto it, I don't know that they would be able to override the veto. It would depend on the vote that sent it to his desk.
Yeah, I think that's a good point. We do have a lot of folks on both sides that are opposed to the bill, so that we've talked to. So that's a good point. All right. Any other questions, comments on this one? I'd say it's, it got a little farther this year, but still a success story that we've been able to keep the mandate in place for now. Do you have another question, Dr. McKee? Or are you just cheering? All right, let's go on to the next one. So this is to increase Medicaid reimbursement rates for dental providers. We talked a lot about this in December and the need for this. This is a bit of a complicated answer as to where it sits right now. So some simple things to understand about the state budget and where it has landed at this moment in time is that House Bill 1 and House Bill 6 are among a slew of budget bills, but contain a lot of the biggest portions of our spending budget for the state for the next 2 years. House Bill 6 is what we have been mostly thinking about as the recurring expenses. What does the state budget look like year after year? And House Bill 1 has a lot of what they're calling one-time expenditures. There's a surplus in the state budget, and so they outlined several things that they're saying, for now, this is a one-time expenditure, and that's in House Bill 1. So House Bill 6, the initial version that came from the House, did not have any sort of specific increase for any sort of services under Medicaid. They funded Medicaid, but they didn't talk about any increases. And then the Senate came up with their own version of House Bill 6, and that actually included some specific line items about Medicaid dental services. It included money for increasing rates, which we were really excited to see. And it also included some language talking about MCOs reimbursing in a more consistent manner, so they could not reimburse less than what the Medicaid fee-for-service program was at. And we were, really happy to see that language as well for some consistency in rates for our providers. Now, there's been a lot of action on bills in the last couple of days, and essentially what usually happens is the House comes up with a budget, the Senate comes up with their own version. Of course, those don't always match, and so they do what they call a conference committee, where they have members of both chambers come together and talk about negotiating out the differences and seeing where it's going to land ultimately. And a lot of that has happened in the last few days, and what we know now is that the line item about dental was removed from House Bill 6 in the final version from the free conference committee, and it was unclear as to why. I did not hear a lot of discussion about it. However, we found out late last night as they were passing the final version of House Bill 1 that a big chunk of Medicaid dollars that were missing from the final version of House Bill 6 were added into House Bill 1 as a line item that just says, I heard on the floor last night a legislator say, just in case Medicaid needs anything, here's this chunk of money. So that was sort of an interesting way to frame it. And I would, encourage folks to weigh in if you've been following this and lobbying on these issues, because it is a very complicated process. But I would say the dental rates, from what I have seen, have the specific language has been removed around that, but there might be opportunity for work within DMS to where that additional money that they're being awarded goes and how they use that in their own rate schedule. So Dr. Robertson, I see your hands up. You might have something to add to that conversation.
Just a little bit. This has been probably our primary focus for the entire session. And it has been implied, is the best way that I can put this, that there is money in House Bill 1 to cover dental increases. The only problem with that is that there's no language stating that. Mm-hmm. So basically, they've given a blank check to DMS, and there's no direction that came with it. So we now have to work with DMS to see what they decide to do with that money. I can tell you that we've been in constant communication with Commissioner Lee. She's very open to this. We had a plan moving forward, depending on the amount of funding that we received and how we were going to do this. Not to get in the weeds with everybody, but all Medicaid reimbursements are based off of Medicare levels. There is no Medicare for dentistry, so there's nothing for them to base their reimbursement levels on. So our reimbursement levels in Kentucky are based on the fee-for-service traditional Medicaid program for the special needs population. This is a $3 million program. That's the total budget. So if that becomes the floor, that the MCOs have to meet. We're not talking about a great deal of money to be able to recreate that floor. So we have a plan. We're moving forward. We're hoping that we're going to be able to work with Commissioner Lee and Secretary Freelander. But our only thing that we're waiting to see is how this is going to shake out, because it has been inferred that we were included in the $65 million in House Bill 1. But again, there was no specific language to that. So we're not sure how this is going to end up. And I think it would be fair to state that we're not done. There are ongoing discussions, and there may still be a pathway for other funding and other protocols. So keep watching your emails and your mails and your updates, because we may only have 2 days left, but don't be surprised if we pull something out of a hat.
I appreciate that, Dr. Robertson, and we know that you all have done so much work on this issue this session, so we appreciate that. And you know, you heard what Dr. Robertson shared and what I said as well about the money going to Medicaid in more of a blanket fashion, like not earmarked for anything. There might be additional advocacy work that we need to do. There might be some work within DMS or, you know, with the state in that way to think about how that money is spent. So we encourage folks to be, you know, like he said, reading emails, looking at action alerts if we send things out or need support on that. So appreciate everyone for that. Anyone else have questions about this? Additions? Yes, Dan.
What percentage of the Medicaid budget is devoted to dental right now? Like 4 or 5%, say?
Well,
2.5?
you want me to take this?
Is it like 2.5 or 2.7?
We've been told for eons that we were 2% of what's considered the MCO budget. So the MCO budget's 13 billion, 2% would be 260 million. The total 2022 payout was 134.5, just over 1%. So
that's ridiculous.
That's the reality. That's what we've been dealing with, and that's what we've been presenting to the legislators this year. You know, and keep in mind also that part of our argument as we've moved forward in this is that over the past couple of years, we've added dental community health workers and adult expansion programs with no increase in funding. So that's two potentially very large things. I'm going to talk about dental community health workers later as part of all this, but you know, there are a lot of question marks. We had a very active session, and like I said, we're still hopeful. But the reality is they've always told us 2%, but we're getting paid 1%.
Yeah, thank you for that question. All right, others on this item. More work to come, more updates to come still. All right, I'm going to move us into the next one, which is protecting the oral health services that are currently covered in our Medicaid program. As everyone is probably well aware, there was an expansion in the last 2 years for more comprehensive coverage for adults under Medicaid in Kentucky. I'm not going to get into all the history of this. If you're really interested in what's happened over the last 2 years and you're not aware, we have a blog that kind of walks through a lot of the steps of what's happened. But this session, the thing to know is that really nothing has changed. It was a bit confusing because Senate Bill 65, once again, was moving and I think has now passed through the legislature. And this is a bill that has been filed year after year, and it doesn't always apply to dental, but it does nullify any regulations that have been found deficient within the last year. So in Kentucky, there's a process where as regulations are written, there's a committee that reviews those, and they have the opportunity to, you know, approve them or find them deficient. They find very few deficient, but one of the ones that they did in the past few years has been related to expanding dental benefits. And as that has moved through the process, there was 2 sets of regulations last year around this. One was emergency, so it goes into effect immediately for a set period of time. And then there was ordinary regulations as well that as soon as the emergency expired, those live on. The emergency regulations were found deficient last year for this. And so Senate Bill 65 was nullifying those emergency regulations, which are no longer active anyway. So it was just taking them off the books for sort of formality purposes. The ordinary regulations were never found deficient. They were heard by that committee and allowed to stand. So those are currently active, and really nothing has changed in terms of what is currently happening in Kentucky under those regulations. But just wanted to share that in case you've seen anything about Senate Bill 65 or we're following along in that process. Questions about this one? Okay, great. And last but not least, is some efforts around youth initiation of tobacco and nicotine products. We have quite the explosion of vaping, especially among young kids in our state. And I know that there are a lot of folks in the oral health space and a lot of other spaces that are really concerned about this trend and the impacts that it's going to have over time. So we had a couple of bills moving that were talking about protecting youth from vaping. House Bill 11 is among them. The initial version of that had some elements in there that we thought were going to be helpful in enforcing the tobacco 21 law that we have in the state so that we don't have retailers selling to kids. But that bill has changed some over time. It's been combined with some other efforts, and ultimately it was weakened with a lot of the changes that we saw in terms of the provisions that help with the T21 enforcement. So that bill passed last night. It is not going to have a huge impact. We don't see it having a huge impact on youth sales, but there are some provisions that I think could build on in the future to help us better enforce that and keep the products out of the hands of kids. And then the other ask that we were looking at was some increased funding to help with prevention and cessation efforts. So if folks do want to quit, they have some support for that. And unfortunately, we did not see any increases included in the most recent version of the budget. So that is just something that we're going to have to continue to beat that drum to see if we can get some more state funding behind those efforts. Questions about these bills or investments? All right, much more straightforward. Okay, so with that being said, that kind of gets us through the policy priorities. And as I said, we still have a little bit left in the session, 2 more working days in the middle of April. So be checking on our listserv as we give updates about kind of the final wrap up and what happens with any of those bills. I'm going to quickly, Dr. Robertson.
Well, before you move on, there was something that I thought of about the Medicaid discussion that I just wanted to talk about real quick. What they did do in the budget in 6 was that they are doing a full system review of Medicaid through the next fiscal year, top to bottom, inside out, not just dental, everything. And then they're going to report back for action in the next fiscal year. And in that second fiscal year, they did do a line item allocation of $25 million. And it's basically going to be up for grabs for whoever needs it the most. So there is the potential of some increased Medicaid funding in the second fiscal year of the biennial budget based on the outcome of the review. We hope to be included in that, depending on what shakes out in the next 2 days that we have available. But there are some avenues there before the next budget period for some funding. And I forgot to mention that. I just wanted to say that.
Yeah, thank you for that. As you all can tell from the discussion here, it is a pretty complex process. So there's a lot that goes into this, and we try to simplify it as much as we can for those who aren't following it closely, but I think it helps to have some of the context as well. So thank you for sharing that, Dr. Robertson. Okay, so quickly before we move into the bulk of our discussion and our panel today, I'm just going to talk a little bit about what is on the radar of KOHC right now, what we're planning for the rest of the year. We are really excited. We're still working on finalizing a new set of patient educational resources. We talked about this a little bit last year and have been we did some surveying of what kind of resources folks want, what those could look like, did a process to draft those, and they are now in the design phase. So we're really excited to be rolling those out here in a few months. And we are also planning to do sort of a revamp of that page on our website to make it a little bit more easy to navigate, have more resources available for folks and links to other places where you can find really great oral health resources. So all of that is in the works and coming soon, and we will be rolling that out, I think, in the summer. So if you all want to keep an eye out for that. And then the other thing that we have just listed here as a reminder to folks, we will do a virtual coalition meeting in June and in September. The dates on those are not finalized yet, but they will be coming soon. And then of course we will be planning a larger annual in-person meeting in December. We had a really great meeting last December, so we're looking forward to doing that again this year. So that's kind of what's coming up for the rest of the year. And I wanted to take a few minutes before we dive into our panel discussion to see if anybody, any members have any updates or anything that they'd like to share with the group while we're here. Yes, Dr. Robertson.
Sorry for talking so much. While we have this group together, I wanted to talk real quick. I'm sure a lot of people have seen the change in the suggestion on the use of lead aprons that came out of the ADA research department. And I just want to remind everyone that we do have a regulation in place in the state of Kentucky that mandates the use of lead aprons. So while the recommendation from the ADA has been to suspend that, and that you can stop using those aprons until that regulation is removed, it is actually a legal requirement in our state. Julie may want to say something about that real quick because I know she's aware of the efforts that are going into that. They are working on it, but as far as I'm aware, it is still in place. So in the state of Kentucky, you are still required to use a lead apron.
And Dr. McKee, did you want to add anything to that?
Sure. I really don't know the exact efforts going on, but I do want to report that I have made a request twice to the radiation branch to help them update the regulations based on the research available for that. And I've heard nothing twice. So being the meanie I am, I'm going to give him another week and then I will start working my way up the ladder. That's how I work.
Thank you for that. Appreciate the update on that. And Dan, it looks like you have your hand up as well.
Yeah, God forbid we depend on evidence-based research in order to make decisions. But let me ask this question. We're in West Virginia on the border, see a number, obviously, quite a few Kentucky patients. In West Virginia, we do not have that regulation. So we have discontinued their use other than for those that request it. We have it, we have it posted in all the operatories and that. Are we in compliance for Kentucky Medicaid since we're but we're physically located in West Virginia? Can anyone answer that question, or is that something for a pay grade higher than everyone else's here? Like
I'm gonna let Julie handle that one.
Well, actually, I think Jeff Allen's on the call, and I think he can handle it more better than I can.
Jeff?
Yes, Jeff, if you're here.
Yeah, I'm here. Can you repeat the question exactly? You're in West Virginia.
Sure.
And
we are located on the borders, Louisa, Lawrence County, and Boyd County, and Greenup County. We have a number of health centers in West Virginia. We have quite a few people from Kentucky that come over and seek dental services because they have a difficult time finding them in Eastern Kentucky. We have since discontinued use of the lead aprons only because of obviously evidence-based. There's no mandate or there's no regulation in the state of West Virginia that we have to use it. So we discontinued them based on the evidence. And I'm asking now, what I'm hearing is that Kentucky requires them. So do we need to use those lead aprons on Kentucky patients and not on West Virginia patients? Or because we're located in West Virginia, that's out of the Kentucky jurisdiction? I don't know if does that make sense? The question.
Oh, yeah, absolutely. I mean, my understanding of it would be that, you're in West Virginia, you should follow West Virginia law. The regulation is it's not a board of dentistry requirement. So I know that we wouldn't have an issue with it. And I can't, I mean, that's really, that's going into the weeds with that kind of question, but I can't imagine that there would be any kind of issue with that.
Okay, thank you.
And also it is not a Medicaid requirement.
Okay,
it is whoever licensed your machine.
Your facility. Gotcha.
Yeah, the radiology branch.
Okay, fantastic. Thank you.
Wonderful. Okay. Other member updates or questions or things that you feel are good for the group to hear before we move into the panel?
Hi, everybody. I'm Tracy Pulley. I run the Family Resource Youth Services
Hello.
Center at Fulton Independent. Fulton is the last county at the southwestern corner of the state. So people here with medical cards have to drive up to Mayfield, 25 miles away, or Paducah, 50 miles, because we're on the state line with Tennessee and Missouri. So a Martin, Tennessee dentist has started taking the Kentucky Anthem card in an attempt to help us because the dental problems here are worse and worse. So I stay in touch with Emily Beauregard, but I just wanted to introduce myself and say that on my end, as you all know, I think, teeth are getting worse and worse, and it's really scary. So I appreciate hearing everything everyone's doing on the advocacy side.
Thank you, Tracy. It's so good to have you on the call. We appreciate you being here and engaging with the group, and we look forward to working with you more on some of these issues.
Alicia, can I share one
Sure.
very quick thing? So we know that Medicaid is going, just thinking about what Tracy said, how hard it is for Medicaid members to find, dentists that are accepting new patients that are also accepting Medicaid. We are working with DMS on a survey that they'll be sending out to members, and it's the first that I'm aware of that's going directly to Medicaid members. And so I think that survey is going to give us a lot of good information about access issues. We're also working on a form. It's called right now Access to Services, and it would be essentially reporting when you aren't able to access a service that's a covered Medicaid service. And so once that form is, ready for use and we can disseminate it, I think it would be great to really focus on, that access to oral health piece and make sure that when people are looking for oral health services and can't find a dentist, that they complete that form. That'll be a way for DMS to start tracking it. And then KVH is going to be doing some listening sessions just to really complement all of this so that we can better understand where the issues are. And it won't be exclusive to dental, but we will include some questions related to it.
Thank you for that, Emily. And we will definitely be looking out for when those are live, and we can share those with our listserv as well to get it out to the full group. And it looks like there is a question to maybe connect with Tracy in the chat. So if you're comfortable sharing information for somebody to connect with you via email, that'd be great. And then I'm seeing, does anyone know if there are incentives to businesses who offer smoking cessation discounts on insurance premiums? I do not know the answer to that question. Is anybody else aware of businesses who offer discounts for smoking cessation? I will write that question down, Carrie, and see what I can dig up and reach out to you if we can find any information on that. And Dr. Robertson?
Well, just for Emily, have you all talked about doing a survey of the providers also?
That's not something that we were considering doing with the listening sessions, but DMS is doing a stakeholder survey. And I'd have to go back to see, but I think that provider is one of the options. I don't see why it wouldn't be. And so that should be a good opportunity for providers to weigh in on other issues. It's not all about access to care. That's a broader survey, but I can check. Haven't looked at it for a while.
Thank you.
All right. Anyone else? Questions? Updates? Okay, wonderful. Well, with that, I want to frame up our next discussion just a little bit to tell you sort of where this panel idea came from and what we're hoping to hear and learn and what we might do next. So I think everyone is well aware, and we're continuing to hear through today's conversation, that access to care is a huge issue in Kentucky. And that looks different for a lot of people. We've heard about what specific barriers are out there, and those vary from community to community and for different people. So what we wanted to start looking into were what are some of the options that are out there for increasing access to care for Kentuckians. We want to think about, what are innovative ideas that have not been done or are new and upcoming, but we also want to hear about things that are happening all over the country that maybe are not happening yet in Kentucky, and see how those might fit into our landscape here. So today's discussion, we are hoping to hear about probably different ideas about what access to care could look like and how we can improve it in our state. We're hearing from some different experts around Kentucky and also nationally on the call today. So we're really excited about that. So what I'm going to do is quickly run through who our panelists are. I'm going to take the slides down because we really just want to see people's faces and let you all talk. But I want to introduce everybody who's with us today, and then I'm going to turn it over to a facilitator to walk us through some pre-written questions that we want to get through, and then we're hoping to open it up, have some time at the end for folks to engage and ask questions. Some of you all sent us questions in advance, so we have those kind of on deck. Again, I'm going to remind you to please use the Q&A feature at the bottom of your screen, because that will help us on the back end to sort through them, and if we have duplicates and things like that, we're not digging through the chat. So if you could use that, we would appreciate it. And so with that, I'm just going to go through our panelists and who they are, and then I'll go ahead and turn it over. So first we have Laura Brannon, who is with Community Catalyst, and that is a national organization. She's a project manager in their dental therapy branch. We have Dr. Whitney Dietz, who is a dentist from Aspen Dental in, I believe, Owensboro. We have Dr. Steve Robertson, who we've heard from a couple times this morning. He is, of course, the executive director of the Kentucky Dental Association. And then we also have Julie Smith, who is a hygienist and also the director of dental services for the Cumberland Family Medical Centers, which is in southeast-ish area of Kentucky. So we're really excited to have them here. And then somebody whose name did not make it on this screen, but I definitely want to make sure and say it. I know she had she was a little unsure about spring break plans, but she made it and we're really excited to have her here. And that is Heather Lubin, and she is an advanced dental therapist from Apple Tree Dental in Minnesota. And if you all are not aware, they are one of the first states that authorized dental therapy. And so we just wanted to hear from somebody in that vein as well. So with that being said, I'm going to take our slides down and turn it over to, make sure I know how to do this. There we go. Turn it over to Shannon Moody, who is our Chief Policy and Strategy Officer at Kentucky Youth Advocates, to facilitate our panel.
Thanks, Alicia. I'm really glad to be here today to help facilitate this conversation. I'm looking forward to learning a whole lot because this is definitely not my area of expertise, but I am glad for folks to be so engaged and already popping questions into the chat. We will first start by talking about some broader kind of framing questions. We're going to dig into access a little bit further, talk about some concerns, and then we're going to get into some more specific and targeted questions that were submitted by steering committee members and other folks in advance. So really glad to, again, be here. And this question is for all of the panel members, probably a little less relevant to Heather, but for our Kentucky folks, what are some of the biggest challenges to accessing dental care in Kentucky? And in particular, what are you most concerned with?
Are we just drawing straws, or who goes first?
Sure, jump on in.
Well, I think we have two overwhelming issues in the state of Kentucky. One is that we have a critical shortage of hygienists. And I really, I guess maybe I shouldn't have gone first because I don't want to steer the whole discussion here, but I feel we're kind of putting the cart before the horse because we're talking about potentially inventing a new level of provider in the state of Kentucky when what we really need to be focusing on is finding a way to increase the number of hygienists within our state to keep this system going. Over and over, the stories that I get from people when they talk about having problem finding access, it has to do with getting in for hygiene visits and how long they're having to wait because of the extreme shortage that we are having. And it's also affecting workforce in the payroll issue, because obviously when you have fewer people available, it becomes a bit of a bidding war, which I'm sure the hygienists are really enjoying. But there's, it's that kind of leads to the second part of the argument. I think one of the things that we really need to be working on together in this group is finding ways to open pathways for hygienists. We are in talks with Murray State about forming a new hygiene program. We're going to be going to KCTC to try to get some of their programs back in Western Kentucky. I'm sure most everyone is aware that I think right now we currently only have 5 training programs in the state, and they're not, the sum total that they're producing on a yearly basis isn't enough to fill the need. We need more training programs. But the second part of that, secondary to payroll increasing because of the workforce issues, is the reimbursement levels in the state of Kentucky. And I mean, across the board. And that's truly my biggest concern with looking at an idea like a dental therapist, is that while I understand people's opinion that they will come in and provide access maybe in some areas, we're having a real problem getting dentists to go to the rural areas of Kentucky where we're 80+% Medicaid, because Medicaid's currently paying 35 cents on the dollar and no one can afford to work at a loss. That number's not going to change whether you're a dentist or a dental therapist. And we need to be working together to try to move that number up to where it's economically feasible. So those are our biggest problems. And secondary to that is our ridiculously low Medicaid reimbursement, which is always near the very end. We're always in the lowest 5 in every reimbursement survey, whether it's Medicaid or private insurance or whatever. The private insurance companies base their reimbursement levels roughly on the Medicaid reimbursements. So right now, the problem that we're running into in Kentucky is that if you ran a hardware store instead of a dental office and you had a grill that was $100, as your bills went up, you would raise the price of the grill. In a dental office in Kentucky right now, because we're 95% managed care, if you raise the price of one of your services, all you do is write off more money. You don't change your bottom line. You do not change what you collect. So our offices are trapped right now, and we have a lot of dentists that are struggling. And I'm afraid if we invent a new level of provider with a dental therapist, we're going to put them in the exact same situation, because their payroll is going to be the same, their supply bill is going to be the same, their equipment cost is going to be the same, their reimbursement level is going to be the same, and the dentists are struggling to go to these rural areas. We actually have students that went and talked to legislators this year and told them that not only are they having to decide can they practice in the rural areas of the state, they're having to decide if they can afford to practice in the state of Kentucky. And that's where we are right now.
Yeah.
So, that's true. I really think that the two things that we need to focus on are building hygiene up, getting the level back up to where there are enough hygienists to meet the market need, and finding a way to increase the reimbursement levels in the state. And I understand the problems in Fulton County and some of the other areas, but you have to understand that the vast majority of dental offices are small businesses.
Mhm.
They're under no umbrella. There's no corporate entity to protect you. And when you're being told that to see these people, you're going to work at a loss, there's only so much of that you can do. A lot of offices have decided that they can no longer participate. And a lot of the offices that are participating because they feel like it's the right thing to do are having to severely limit the number of those patients that they can see because of that reimbursement level, because they're losing money to do it. And we need to be working to bring that forward. And that's why we've made this our number one push in the legislature. It's not the panacea. It's not going to fix everything. But if we can improve the reimbursement levels, we're going to be able to bring more providers back into the program. You're going to see an improvement in access to care.
Yeah. And Dr. Robertson, we're actually seeing some parallels in some other health related, not oral health, but behavioral health And even in childcare, seeing some parallels with not enough access, or access being really hindered by the lack of appropriate reimbursements, and creating deserts for people to not be able to have access to that care that they need. So I heard, obviously you talked about the shortage of hygienists, long wait times. You had mentioned some needed pathways for hygienists, and then those reimbursement rates being really a clear hindrance to access. I'm wondering if some of the other panel members had different observations or observations that they're seeing that are regionally specific to access or lack of access.
You're on mute, Whitney.
Okay. Can you guys hear me now?
Yes.
Okay. One of the issues that I am seeing, even in a year-over-year, get tremendously worse, is in the program that I volunteer with in Western Kentucky called the Floss Gloss program. Leah Smothers, who's a public health hygienist, she is seeing, last year we saw over 600 unique patient visits, and I supervised that via teledentistry. And she was able to provide intervention and prevention, including SDF, which I think is something that's another piece of the discussion for later questions that I want to bring up. But the status of those children's teeth last year to this year, tremendously worse. Yesterday I reviewed 20 charts. I had 5 children that had non-restorable permanent first molars out of 20. Not to mention rampant decay elsewhere, and in a position where many of these children were seen last year and haven't had access. So the list of available providers is small, which of course is something that Dr. Robertson is emphasizing, because you can't afford to treat these patients as a dentist. So I think that our current system requires some outside of the box approaches to alleviate some of these pain points. I feel for the adults in our state, but what I am seeing in our children is devastating. We are going to be edentulating a 13-year-old and a 15-year-old later this month that are referrals out of that Floss Gloss program, and they will not be the first or the last. And it's because of gross dental neglect. And we all know that puts those children at a lifetime handicap compared to their peers with function, with speech, with confidence, with health. So I see those kids as a priority. One thing that I think could be or should be part of the discussion is reframing how we think about Medicaid reimbursements. I've seen some of this even in the context of my practice, not where I volunteer, but where I make my living, which is being a multi-practice owner with Aspen Dental. Some are giving like a flex card. I see this as a great idea to, instead of have to bill Medicaid, give your Medicaid participants X number of dollars on a flex card to be used at any dentist. Then you can bill whatever you want to bill, and they can choose whoever they want to see. And then when they exhaust that benefit, even if clearly, if it's $1,000, if it's $2,000, whatever it is, they exhaust that benefit and they're much healthier at the end of that year than they were before, because they can't find anyone to treat them because no one can afford to treat them. So I would just encourage this coalition to think outside of the bounds that we are currently in, because everyone that is on this meeting, so many names I read through in preparation for this of people that I tremendously respect that have moved oral health care in our state forward. And there is a better way. There must be a better way outside of our current concerns.
Dr. Dietz, it sounds like you've got some optimism around the opportunities here. The example of the flex dollars is a fantastic idea. I'm wondering if Julie or Laura have heard or seen some innovative access-oriented strategies, or are wanted to discuss a bit more about what the lack of access is looking like where they serve.
I call myself a recovering public health dentist. I've given my time and gone around to my community, and I'm never going to be the same, but I'm, also the only one that's really even partnering with my local health department or the FQHC to even see 4 patients a month. And so, it's hard, but, I have regular insured patients that whenever they need extractions, go to the oral surgeon and they're like, you're going to need to have $2,000 down before we can schedule your appointment. It's a barricade for everyone. So, that's when we get out there and go to where the people are, that's how we can make a difference. It's all about the case management. Try and just put out the fires with, I love it when Nikki would always say she felt like she was putting out forest fires with a squirt gun, but that's, really kind of where we are. And, we just have to get some more hygienists that can get out, get some prevention programs, get some referral programs, get some things going, because, 4 people at a time is not where we need to be. And that's basically where I am. And I know that there are a lot more people that would love to step up, but we're struggling. Technology is great, but it's expensive, and doing dentistry and the way that we're recruiting students is completely different. I had a really unique experience yesterday that there's a Western Kentucky Consortium kind of amazing healthcare van. Man, they are really pulling out the stop to get these nursing and other students really engaged. I mean, I walked in that thing and I was like, wow, this is so cool. A whole room where all the walls are computer touchscreen, and, there was no dental, and it's just like, working with these groups that did receive funding. They're apparently doing a whole 40,000 square foot fixed location in Owensboro. Does that have dental in it? I don't know. But, it's just like, well, we need to really think about how we can recruit, because I tell you what, I was about to sign up for whatever it was to play with all that stuff. It was really pretty neat. So I'm optimistic that we see some of those things happening, and, we're really engaging, but we need people to be interested in the fight.
Yeah, I hear you, Dr. Hancock-Jones. I think we've got 2 folks on the panel, Laura Brannon, who's been kind of following the trends along access. I don't know, Laura, if you wanted to respond to the question around access as well.
Yeah, I'd love to. Thanks, Shannon. And hi, all. I, should start by disclosing that I am not in Kentucky, but I work nationally, and I work with advocates in Kentucky and folks all over the country. And I got to say, a lot of the stories I'm hearing so far today are really similar to stories that I'm hearing in other states. I think the thing that I want to say first is, to me, this is not an either or, this is a yes and, because these are problems that are serious and that they're also long-standing. I feel like the stressors of the pandemic in the last few years have gotten us to a breaking point, but these are not new problems. And so I think that it's really important to remember that this didn't just all suddenly happen. And so, I want to respond to a couple of the thoughts that have been shared so far, and also talk a little bit about what I'm hearing from an organization that works to help people all over the country sort of have a say in their own oral health decisions. And the biggest thing that we hear is that oral health care is inaccessible and unaffordable for people all over the country. It is one of the leading drivers of medical debt in this country, is people going into debt over that. And I hear so much about oral health and the cycle of poverty, about how being poor gives you poor oral health and how it keeps you poor. And I think it's really important to think about solutions that are coming from more angles than just doing more of what we've traditionally done. Because if we're really trying to break this cycle, I think we need to look at what are all of the reasons people are winding up with poor oral health? What are all the barriers to them getting care? And most importantly, what do people want from the oral health care system? And I think that is often a voice that we don't hear as much about. People have ideas that, patients, particularly patients with Medicaid coverage, don't care about their oral health, that they don't understand the importance of it. When I got to tell you, in my work, that's exactly the opposite, but they feel like they are in a healthcare system which doesn't care about them. And so I think trying to figure out what do patients really want and what do they need, and really prioritizing that. And yeah, so I'm excited to talk more about hygiene and about dental community health workers and about dental therapy as well, which I work on. And I just really want to emphasize that I think this is a yes, and because this is not a new problem, and this is something we're going to need, all hands on deck to actually really solve, and not just to get us back to where we were in 2019. Because let's be honest, in 2019, we still had really serious problems. Less than half this country getting dental care. And it is one of the major drivers of health inequities in this country. So it can't be, let's just get us back to where we were pre-pandemic. We need to really make some deep structural changes if we're actually going to get oral health improved in this country.
Laura, I'd actually like to call back to something you mentioned about making sure that we're hearing from the communities, understanding what folks want. And I'm curious, especially to hear from Julie Smith, who's in the Cumberland region and overseeing school-based programs. What are you hearing from kids and parents or your community members about access?
So I'm listening to the people who spoke before me, and I was looking for an emoji that just said amen. And I just wanted to be the amen corner over here, because I agree with everything everybody said. And when I looked at these questions and it asked biggest challenges, I thought, okay, the obvious stuff: providers, dentists, hygienists, lack of moving forward into new realms that could bring care to different areas, and so on. So all the obvious things, Medicaid reimbursement, all the obvious things. And then I tried to get a little more regional and a little more local into what I was thinking. And one of the biggest things that I deal with access to care. And this year, my mobile program started a restorative program in 4 districts. We rolled it out slowly. We found a dentist. We got her expanded duties assistants. So we overcame the not having the providers. We sent the providers to the school. The CEO said, I know you're not going to make any money doing this. I'll fund it. Let's do this anyway. So we overcame the obstacle of, we're probably not getting paid what we should. And we still struggled because we couldn't get the parents to fill out the consent forms. So I'm going to tell you the biggest barrier I have dealt with this year is that lack of understanding, that lack of knowledge that oral health is related to your overall health, that for your kids to be healthy, we need to treat their mouths just like we treat their mental health and their physical health. We need the opportunity to do that. So we have an adult population in the state of Kentucky, not the entire population, obviously, but a huge population that just doesn't get it. And it's going to be hard to change that unless we are going into the schools, even if it's just for the sake of educational programs, teaching our children why this is so important so that our next generation of adults has a different mindset. We've got to change the culture of these communities. And to do that, we're going to have to go to them.
Yeah, I love how you are thinking about kind of shifting mindsets, right? That's going to take time. That's going to take innovation and education. I know, I think Dr. Robertson had mentioned outreach and engagement. And I think maybe you'd mentioned community health workers as part of that process. Dr. Robertson, would you like to talk a little bit more about your ideas there?
Well, first, I want to echo exactly what Julie said, because one of the things, as people were talking, that I wanted to share is that my wife is also a dentist, and she works part-time with a group named Big Smiles that actually goes to schools and does work more than screens and scans and maybe polishes teeth. They do restorations, but they have cases that are too big to handle in a setting like that. And what she is seeing now that she's been with them for about 7 years is that these kids keep coming back without that work ever getting done. And it's not for lack of a referral, it's for lack of concern by the parents. And, there are things that are going to be very difficult to change that we're going to have to think of above and beyond. And we can all tell horror stories. And I've seen the kids that have to have full mouth extractions. I understand what you're talking about. I was a Medicaid provider for years. And, there's a big education aspect to anything we're going to do, because this is the classic, you can lead a horse to water, but you can't make them drink. One of the overwhelming problems that we run into with the Medicaid population, if that's what we're discussing, is no-shows. There's offices that they don't just double book, they triple and quadruple book, hoping one person will show up for an appointment, and they're already working at a loss. Now, that is where I think the community dental health coordinator can be just unparalleled. This is untapped in the state of Kentucky, and we have had the ability to request funding through Medicaid for this position since last June. And last time I checked with Commissioner Lee, there hasn't been one claim filed yet on that fee. So we need to get this active in this program, so that, and we need to educate the dental offices how this program can help, because this individual is there to help remind families of what's going on, help try to cut down on the no-shows, help deal with transportation issues. Those are the kind of things that these individuals are supposed to be able to do. And I think that this has always been the missing part. And to be quite frank, in most dental offices, there's been someone that has attempted to fill that role, but on a very, very, very part-time basis, as they did everything else they were supposed to do. So I'm really hopeful that educationally, this is something that we can move forward with. And this is a program that already exists that we don't have to recreate. And, that combined with increasing hygiene and assisting training programs to work on the workforce issues, I think will alleviate a lot of it. But, going out, having programs like Miss Smothers that goes out and takes the care to the people, having programs like those that are provided by the mobile vans that provide care in schools. I realize that there are people that ruffles their feathers, but a lot of those kids that are seen in those environments and the people that care is made available to, that's the only way that they're going to receive that care. So I do think that a lot of it is going to be, we're going to have to come up with ways to take the care to you. And those are the kind of programs that I think we need to be working together on.
I'm wondering if our panelists would like to respond to that. I see Dr. Dietz coming off mute. Beautiful.
I think that what Dr. Robertson is saying right there could be a laser focus for real change. When you're talking about vulnerable populations, you have inability to show up for your appointment for a myriad of reasons: transportation, money, job, drugs, abuse, neglect. I can't afford to put gas in my car, like a myriad of reasons. And then when you have the system to take the care to the people, then there's the issue, especially in minors, of consent. One of the ways that Ms. Smothers has overcome some of that is that paperwork includes multiple consents, and it goes out with their beginning of school paperwork. It's not a secondary consent, because I have 3 daughters, in the school system. And I can tell you, I missed 2 picture days this year because I didn't look in their folder. And I'm a dentist. Okay. So, you know, if I'm not looking in the folder and I'm like, oh my gosh, another form, how many of these things do I have to throw away? What's important? Our most vulnerable families are not being attentive to those things. We need to make it very easy to where it's nearly passive on the role of providing consent. Like, okay, I'm already consenting to all of these things. Do I want this free program? Yes, I do. Sign, sign, sign. Here's the information. So I think that's one small thing. When we go to the people, then those barriers are then removed. And ensuring, and then in using the money that's already there with what Dr. Robertson is discussing in our existing practices to make sure the patients show, that eliminates some of the provider hesitation. I was speaking with a dentist yesterday who works part-time for me, and the rest of the time she works in a free community clinic, not just for Medicaid, but for anyone who can't afford. And she said that even though all of their services are at a 0 fee, they still have a significant issue with show rate, even though there's no cost. So getting them there, either getting them there or going to them. So I think that should be a focus of not only going there, but then expanding the things that the people that go can do. The application of SDF, clearly they're already doing sealants, things like this. This is an area where I do think that, you know, potentially not now, but certainly in the future, a dental therapist, their salary is not what a dentist's salary is. That then they are part of that team that is going to these people to do these services. And then as someone who doesn't make my living in public health, there is a really great element for having general supervision of donated service, like donate that teledentistry. It takes a very little amount of time. You get a tremendous tax break for it. I think that you have a lot of dentists that would be willing to give 20 minutes every other day. And it helps them on their taxes. I think that there are other ways around getting providers on board.
And we've had a couple of comments in the chat and then in the Q&A. Leah Smothers in particular said, you know, she'd like to respond. She said that her public health program has added a dental community health worker. She's currently being trained to become certified. We aren't able to bill because these services haven't been added to the preventative fee schedule. I don't know if we've got a response from from panelists that have any insight on that, or.
Well, Leah, if you could unmute, I'd kind of like a little clarification on that, because what are you talking about specific services that person will provide? Because there's one billing code for the community mental health workers, and it's a time-based code. So there's reimbursement available just to cover them on specific units of time.
I can note that that's D9994, Steve.
Thank you, Jerry.
And it covers not just education, but the commissioner has also said it's to cover transportation, childcare issues, all the barriers of social determinants of health to try to help that patient get in.
As a public health program, our program bills on the preventative fee schedule, not the dental fee schedule. And I was responding to you saying that there was money out there that for community health workers that no one was tapping into. And it's because my program isn't able to do that because it's not on our fee schedule yet.
I appreciate that information, Leah, and I will carry that forward. I promise. One quick comment, because we brought up SDF twice. This is one of the things that I talk about quite a bit, because while most people may not be aware of this, in Kentucky, with Medicaid, SDF is almost treated as a final restoration. And I know Jerry may want to argue with me a little bit about this, but the reason that I put it that way is that there's a time factor after the placement of SDF before you can come back and treat that tooth. And in our state, the reimbursement level for SDF placement is less than $20. In the surrounding states, the average reimbursement for SDF placement is $60 to $70. So that just gives an idea of some of the issues that we're working with our Medicaid reimbursement.
So I know we've talked about some innovative ways to engage and create some more access. We've got a comment from Nikki on this vein. It says, also confusion about billing those visits if they are phone calls, which is the primary way we communicate with families. We were told in December meeting that we would have to meet all telehealth requirements too. So it sounds like the billing pieces are also creating some barriers for providers.
I think it's very fair to say there's a lot of education that needs to take place. I mean, the biggest thing is that the individual dental offices have no idea of how to integrate this program. And, you know, it's one thing to talk about educating the patients, but this is an instance where we need to go out and we need to educate not even necessarily our dentists. The dentists need to understand it, but, you know, your office managers, your front office people are going to have to understand it, because every time I go to these presentations about community dental health workers, we talk about this being the assistant or the hygienist. In reality, those individuals don't have time to do that. They're involved in direct patient care. The most likely person to be your community dental health worker is the person out front on the phone who's communicating with these people on a regular basis. And I think that that's sort of the message that we need to start getting out and working with people. And there's a lot of advocates for this program within this room, because this was something we discussed at the December meeting. And I really think that this needs to be one of the focuses, is really sharing this information and how it can help improve everything, because the entire track of that position is to help bring those people into these practices, encourage them to get there, find ways to help them get their needs met. And it's really about closing some of the loopholes to get them in and find them care.
So I think this is related, but not, but for the panel members, there was a comment and question in the chat from Diana about having any school-based mobile dental programs encountered issues with local providers refusing to see previously established patients if they receive services through those programs. And I saw that both Leah and Nikki had responded that they had seen that, but I'm wondering if the panelists also have any insight on that.
Absolutely. That has, I mean, it's been an ongoing problem, and I've been running this mobile program for 7 years, and I've worked for 7 years to build bridges. I will say that, and it has improved some. I still have a couple of pediatric offices well, one last week, mom called and said, hey, my child was seen at the school. We've got 4 cavities. And they were told, because you let them see your child, they messed up your insurance, and now you can't be seen again till August, and we're not taking their word for it that your child has cavities. We'll put them on the schedule in August. And then we're scrambling and trying to find this child a place to go. As a sidebar, next year, I will have restorative services at that school. I don't know how.
That's amazing.
Unfortunately, I have to agree with Joya. This is something that we see a lot, and in general, it's not in response to restorative care being provided. I think that there are a lot of providers that have an issue with the groups that are going to schools and only doing screenings or prophies, because they feel like, you know, that's cutting into their bottom line. And, you know, again, the only thing we can do there is maybe educate and share that, you know, This is a child that's coming to your practice that probably otherwise would not have come to your practice, because the vast majority of kids that are seen in those outreach programs wouldn't have gone to that dental office.
And on the one hand, I get it. I worked in private practice for years and years. And at that time, the mobile programs that came through our area, well, they just weren't very good. And they weren't regulated. They could do whatever they wanted to do. The doctors came from out of state a lot of times, and they didn't have a stake in that community, and they didn't necessarily care about those kids. Whereas I do believe most of the mobile programs now are based within the state of Kentucky, and you are going to see, you know, the dentist at this school, and then you're going to see that dentist at your soccer game because her grandson's playing on the other team. They're a part of these communities, and these kids matter to them. It's different. And our mobile programs are having to overcome the precedent of the bad mobile programs that came before us.
That's really good insight. Yeah. So I know that we've been talking about some opportunities for innovation as far as engaging the community, meeting people where they are via mobile care. I would like to revisit Dr. Robertson's conversation around both the need for hygienists and then also the conversation around dental therapy. And I'm wondering if we can start first with Heather to talk a little bit about their experience and maybe why the dental therapy became an option in Minnesota.
Sure. Can you hear me?
Yes.
Okay. Thanks for having me. I should say I'm a clinician, so I'm not really like an expert in advocacy or education or legislation politics, but I mean, listening to everybody's comments so far, I think it's pretty clear it's a multifaceted issue that we have really nationwide, the oral health crisis and issues with access to care. I work for a nonprofit organization in Minnesota, Apple Tree Dental. We have 9 centers for dental health, and we provide mobile care at 150 community sites around the state. And I still see horrific dental disease every day. Despite the fact that Minnesota has dental therapists, we've been using SDF for 10 years, and we have really good, I think pretty good reimbursement on that. We have collaborative practice hygienists. We have critical access dental payment programs. So I think even despite having those, there are still, this crisis is so big that we really have to have multiple solutions and multiple ways that we kind of try to fight against it. One cool thing I will say, just listening kind of to what people were saying and just observations about the dental therapy educational programs is that they're 100% focused on treating vulnerable and underserved populations. So I really think, you know, not just dental therapy, but dental hygiene, dental assisting programs could really benefit from really focusing on recruiting public health-minded people. Not just having one class on public health, but really focusing on recruitment of public health-minded students and clinicians, focusing heavily or more in their programs on treating vulnerable populations who face these various barriers to care, and they have really extensive dental disease most of the time. In Minnesota, we passed dental therapy in 2009, and I was part of the first graduating class in 2011. So I've been practicing for quite some time. And we were just seeing that disease burden, and that was part of the reason that we passed the legislation. But again, I feel like there are so many different solutions that it's not just dental therapy, but it is like expanding the scope of practice for dental hygienists or what they can do, utilizing teledentistry more. We use teledentistry quite a bit at Apple Tree. So there's just multiple ways that we really need to tackle the crisis. And I guess I'm happy to answer any questions specifically on kind of my daily practice or what I do if you have them. Yeah.
I would defer to our panelists initially. If you all have questions or just reflections on what you heard from Heather.
Well,
I'd love to
one of the things,
respond.
yeah, go ahead, Lauren.
Thanks, Dr. Robertson. And I have the honor of having gotten to hear Heather speak before, and I love when awesome dental therapists like her get to speak for themselves. And I think like one of the most powerful things we can do is have people realize that we're not talking about sort of dropping aliens into a state, but creating accessible education pathways for people from communities to become the providers that their communities need, which is what they've been able to do in Minnesota and in 13 other states. And so I also realize I'm not sure if everyone really understands what a dental therapist is. So if you don't mind, I can just do a tiny bit of level setting, which is dental therapists are licensed oral health providers who work under the supervision of a dentist. They attend CODA accredited programs. So CODA is the same entity that's accrediting your dental schools, dental hygiene schools, dental assisting programs. So same entity is accrediting them, working side by side with dental assistants and dental hygienists under that supervision of a dentist, but they can do some procedures like exams and fillings and some simpler extractions, which really is going to increase the amount of care that can be provided, increase the cost effectiveness and the efficiency of that dental team. And dental therapists have been in the US for 20 years now. And globally, they've been working for over 100 years. So this really isn't a new idea here or in general. And I want to go back to that part about being able to bring people from communities into this profession, because this is where dental therapy came from in the United States. It wasn't an idea that came from a think tank or from a provider association. It was an idea that came from communities that didn't have access to care. And those communities said, well, what do we want? We have gotten so tired of having poor access to care and poor oral health for so long, of having, only rare access to dentists. What do we need to actually make sure that our rural, low-income communities, these were particularly tribal communities in Alaska, could have access to care? And they said, well, we need providers, we need telehealth, we need team-based care, but we also need to look at what education is actually accessible, and realizing that the hundreds of thousands of dollars and 8 years it takes to get through undergrad and dental school is not accessible for most people. And so having other pathways into education that you could do at a community college, at a technical college, that's considerably more affordable is really important. And so they said, well, how could we integrate this into our care? And the result has been more care for patients, better health outcomes, lower costs, able to stretch those Medicaid dollars further. And I should also say, I'm the first person to say that no one should be losing money on Medicaid payments. But we also know from a lot of research and a lot of experience for a long time and all over the country is that while raising Medicaid rates can give a little bump, it does not dramatically change who participates in Medicaid. And quite frankly, as a lot of other folks have said today, just having more providers accepting Medicaid doesn't necessarily change access. When we need to figure out how to get care to communities and increase that community trust. And I think one of the most important things we can do is making sure, like I know Julia said earlier, that the providers are part of those communities, that they're not just showing up once or twice a year. If they're part of the community, if people are seeing them in the grocery store, if they have trust with their community, it's a very different relationship than with somebody who you only see occasionally. And what they've also seen is when you're bringing care to people where they are, when the provider is part of the community and there is trust, is you're going to have decreases in things like no-show rates. You're going to have patients who are understanding oral health better, and all of that really goes along with it. But I also wanted to just respond to something Heather said, which I think is so important, which is, dental therapists are part of a team, and we need to be thinking about the whole team. And to me, that also means community health workers. We need everyone absolutely to solve these problems, and it means maximizing what hygienists and dental assistants can do. But, I do want to talk about hygienists for just one second, because I know there's a huge attention right now in Kentucky and all over the country to the shortage of hygienists, and that is hugely impactful on access to care for patients and on how dental practices are operating. But I think we also need to think about, how did we get into having a shortage of hygienists? Because if you look at the number of hygienists who have graduated from dental hygiene school in the United States over the last 20, 30 years, we should have more than enough hygienists. And yet we have a huge number of hygienists who've left the workforce. And a lot of the research that has been done about why hygienists are leaving the workforce is showing that a lot of hygienists are saying that they are feeling a lack of respect in their workplace and that they have a lack of opportunity for advancement. As well as, let's be honest, hygienists are mostly women, and a lot of women have more caretaking responsibilities. So a lack of affordable childcare, a lack of, care for sick family members, all of these supports are going to affect the availability of people to work in these professions. So I also think we need to think about how are we making that team-based care, like Dr. Dietz mentioned, really emphasizing a team of providers who work together in mutual respect and in creating opportunities for folks to do more, and realizing that it's not enough to just send people to school and then say, well, we've got more people entering the workforce, so we'll have enough workers. If we are not creating a supportive environment for them to want to stay in these professions, then they're not going to stay. And that's true for dental therapists as well as hygienists and anyone else. So we need to be creating long-term opportunities for people in these professions.
First, somebody sent me a message that something I said may have been misinterpreted, and I want to address that because I am a big fan of Leah's program, and if in my comment of people doing prophies and exams and dentists getting mad was misinterpreted, I wasn't singling any of that out. I was really talking about some of the old programs Julia was that we used to see come through the state. I use Leah's program in Western Kentucky as a shining example of the way we can get things done on a regular basis. So, Leah, I'm a fan. Please know that. But I do want to respond to some of this. Heather, I have one question for you, and please do not consider this an attack in any way, but what town are you located in Minnesota?
Sorry, I was having trouble getting off mute. I am in Mounds View, and so we are a suburb of the Twin Cities area.
And the only reason that I asked that is that, the numbers are the numbers. There's 141 active dental therapists in Minnesota. There's only 3 programs right now that are available for training. One of the training programs in Minnesota recently shut down. What we've seen happen in Minnesota is that the dental therapists have all basically migrated to the metropolitan areas because it's just hard to keep people in the rural areas. And one of the things that I think that we can look at, no matter what we're looking at, you can pick any category. One of the things that I think we need to look at are scholarships and sponsorships. There are a lot of scholarship programs. Julie even has some programs available, Julie McKee, where they do rural placement scholarships for people going to dental school. I'd love to see us expand that to dental hygiene to make sure that we're getting people to go to rural areas and provide care. I'd love to find ways to expand those programs, especially considering the amount of debt. And, really, Kentucky has some of the most liberal auxiliary laws in the entire nation, which may be something that both Laura and Heather are unaware of. But our assistants and hygienists can do almost anything other than prep a crown or prep a tooth. Obviously they can't do extractions, so there are some things there. But we have very liberal auxiliary laws that allows us to use these people extensively in our office, which is why they play such a vital role in this state. And I just am reticent to say that, adding another clinical person as a potential dental type clinical person is necessary. I could easily make the argument that if we need a mid-level provider in Kentucky, what we need is a mid-level hygienist, an assistant who can scale super gingivally so that we can use our hygienists to see the periodontal patients and do the involved surgical type deep scaling treatments and have other people available to basically provide the prophies to the healthier patients. We already have auxiliaries who can do who can do coronal polishing. So it's just another step in that direction to have assistants who can do super gingival scaling to help take some of the heat off of what we're seeing with hygienists, so that, no offense, but if you have a healthy mouth, there's probably somebody that can take care of that prophy. And then the hygienist could be seeing people where their services and their skills could be more fairly utilized. And, I just think there's lots of avenues to look at and there's lots of things to think about. I'm concerned about putting the time and the training and the money into a program that, historically in the other states where it's been involved, they haven't been able to keep these individuals in the rural areas either. Really, outside of Washington, the only other states that they have something actively going on are the states that have Indian service contracts where they're working out there. And, it's just, I think there are a lot of things to look at and consider, but Kentucky is a little different because of our liberal auxiliary laws in what things and people are allowed to do.
So I see both
Could I
Laura
respond?
and Heather unmuted. I want to make sure that we've got just a minute to give you all a chance to respond. And then what we really want to do is then talk about next steps for this coalition, because this has been a robust conversation that I think needs to continue, and then also put some action to it. So Laura and Heather, if you'd like to go ahead, and then we'll get into the action items.
Yeah, I did just want to, I'm so sorry, Heather. Do you mind if I go really quick?
Yeah.
I wanted to respond quick just because I think you had a couple pieces of inaccurate information, which I've heard other places too. So I think that they are common myths. So just, we've got dental therapists working in 5 states right now, and 9 other states are working on implementation. A bunch of states have passed laws just in about the last couple of years. And so they're working on implementation, creating education programs right now. A lot of them passed right before COVID, and that got a little hard to open new programs. So they are expanding really quickly. And there's massive demand for dental therapists in Minnesota. That is the primary complaint I hear at this time from the Minnesota Dental Association, that there's not enough dental therapists for them to hire, and it's driving up the salaries of dental therapists. The other thing I want to say is, dental therapists are working in rural areas of Minnesota, but they're also working in the Twin Cities. There's a tremendous amount of need in the Twin Cities as well. And dental therapists are doing a massive amount of care, of mobile care, which I think is maybe not getting captured in that data, or bringing care out to rural communities. My family is actually from rural Minnesota, is from a mining community in rural Minnesota, where they've had trouble keeping dentists for a very long time. And now my cousin's kids get care, comprehensive care in school-based clinics, which was only possible due to the cost effectiveness of adding dental therapists to the team. And I'm hearing from private practice dentists who talk about how they've not been able to find an associate dentist who wanted to come out and work with them in rural Minnesota, but hiring dental therapists has allowed them to keep their practices going and make them more profitable. So this is actually really working in rural areas and in urban areas. And Heather, I know you do a lot of care in communities, and you can talk a little bit about how impactful this is in Minnesota.
Yeah, you said it probably better than I will, but I should have been more specific. So, and the last statistics I heard, 40% of dental therapists were working in rural Minnesota, 60% in the metro, which is actually congruent with how our population is also dispersed in Minnesota. And quite a few of us in the metro area, including myself, do mobile dentistry, and I do travel, up to an hour and a half away from the Twin Cities into areas into rural areas to provide care. And we have quite a few dental therapists in Minnesota who do that. And yeah, that is not captured when they do those surveys of where you're practicing. It's just, difficult to capture in something like that. So we're listed where our headquarters are, which is in the Twin Cities, while not all of us are only practicing within the Twin Cities metro area.
I appreciate you all both weighing in and the robust conversation. This is not something we're going to solve today by any stretch, but something we're going to continue to talk about and identify what the role is for the coalition in this conversation, as well as just more broadly in Kentucky. Dan, I see you have your hand raised. Is it for a question or comment?
I just want to make a quick comment. I've turned my camera on so everybody can see how old I am. I've been doing this 40 years in community health center. And there was so much here to unpack. You're not even close. And I have 4 pages of comments I'd like to make, and I know we don't have time for that. But I just want to say the system's broken. Real quick, you need dental assistant training programs too. Um, well, there's just so much. The whole dental education, I can go into that because I run the residency program, AHC residency program. And what do you think the first thing the residents want to know about? Implants. I mean, let's be real a little bit and let's train dentists to do what needs to be done. And I'm going to quit because I can go on with the school based, I can go on with vans. There's just so much. So anyway, sometime I'll maybe talk to you personally. And I wanted to also, when I say that, I want to make sure that you can't revoke my membership, right? Okay.
I think we're all safe here.
'Cause I could say enough to piss everybody off.
Hey, you know what? A little bit of conflict, a little bit of friction can be good for change and movement. And so I appreciate you jumping in. And
I speak
you're
from
actually,
experience, and I'm going to mute myself, but I speak from 40 years of being on the front line.
and that is a critical experience to bring to this next conversation, which is really focused on where do we want the coalition to focus when it comes to increasing access to care for Kentuckians? What steps can this coalition take in order to increase care? There were a lot of ideas in the chat dropped in. Some folks were weighing in through the chat. I think what I would like to do actually is just kind of summarize some things that I heard and then have folks respond to, if that makes sense. There was a lot of really good conversations around intentional education for private practice dentists, around school-based regulations, more collaboration. I think Dr. Robertson had an idea around the need for educating private practices on several other aspects of things. So intentional education for private practice dentists. There was a idea around innovative access through expanding the workforce, bringing the workforce to kids. So whether that's mobile dentistry, whether that's a mid-level provider, whether that is increasing access so that we have more hygienists, scholarships for dental students and rural placement scholarships for hygienists and dental students. So I'm hearing intentional education and then innovative access. There was the idea around flexible funds through Medicaid. So maybe some practice or regulation changes needed. Stephen, would you like to weigh in?
Yeah, there's two ideas that I wanted to discuss that hadn't come out yet. One of them was, I think it was Whitney that talked about the Flex Card program. In our first proposal that we took to the state this year, we were actually promoting changing Medicaid to a food stamp type program where you take a voucher out to the dental offices. And that was kind of shot down in a hurry because of the MCO agreements. So there's a lot of discussions that would have to take place because I do think there are some variations on that idea, whether it's a flex card or a voucher or something that you take out. And keep in mind that Medicaid is an uncapped program. If you needed $30,000 in dental care and you chose to do it all in 1 year, you have the availability to get that done. None of the rest of us who are not on that program have that availability unless we're willing to write that check out of our personal account. So there are states that are putting caps on programs to limit expense and things. And I do think there's a lot of things long term that we can look at. But one of the programs that I really want to highlight, and I don't know if anybody caught this on the Lexington News, but it's been getting some publicity lately, is there's a dentist in Paris, Kentucky, Amanda Thornhill, who has started a cooperative program with the local Paris high school through their vocational and work outreach program where they get school credit and they get to go to work. And I mean, a lot of you, when I was in school a long time ago, we had DECA. I don't know what they call it now, where some of those kids involved in that program would go out in the afternoon and work. Well, they're going to work in a dental office. And, those kids are getting trained to be a dental assistant. They're getting that experience. A lot of them are making the decisions to go on to become a hygienist, maybe to go to school to be a dentist, but they're getting in the dental program early and they're able to get school credit, work credit, they get paid, they get in the dental office. There's a lot of potential benefits of programs like this that we could work on setting up with dentists and school systems to get kids out in the community and get them into the dental environment and get them going down the dental pathway for whatever path they choose. And I think that there are a lot of fabulous ideas out there. There's a lot that we can look at, but this one's pretty easy because a lot of those work outreach programs through the vocational schools and even through the systems that don't have vocational programs have work programs where kids can go work for school credit, for school business credit. And then, I just think that this is something that in dentistry has been relatively untapped. And now we have a great example. And I think it's something we can build on.
Yeah, that is an awesome and innovative idea. It looked like in the chat there were a couple of other examples too in Louisville and Lawrence County. The more that we can spread those ideas, the better, and create pathways to future careers for people who are curious about it. So I think that's phenomenal. I know there has been a lot of great ideas. Nikki, I really appreciate you summarizing those focus areas as well around the PHRDHs, a couple of other Profi code pieces. I will not pretend to know what some of those acronyms are, but you all do. So the next steps are for the coalition to hone in and focus on continuing to take action and clarify what that action is to increase access for Kentuckians. Really appreciate the conversation, really rich discussion today, and the panelists have done a phenomenal job. We really appreciate you all taking the time to spend talking to the whole group on the panel and bringing your knowledge and expertise. It's been really, really phenomenal. I am now going to pass it over to Linda Stettenbens to close this.
I have a quick question because as we went through this, I had a hard time keeping up with the chat. And are we going to have access to that after this closes? Will you all save the chat?
Yes. I'm so glad you asked that. And Alicia even reminded me to say something. We did not get to all of the questions in the chat. I think folks are going to gather all of those and follow back up so that all of those comments and questions are captured. Thank you.
Thank you.
All right, thank you, Shannon, for moderating our panel discussion today. Such a rich discussion. I'm glad to hear I'm not alone and not understanding every single thing, but we are all learning a lot. I think everyone here really got a lot out of the discussion. And we know that there are a lot of ways to improve access to care. We're excited to see what we can do about that. And Alicia and I really depend on our KOHC members to share your wisdom and your advocacy to lift up the best ways to improve the oral health of all people in Kentucky. If you're not already a KOHC member or you need to renew your membership, you can do that by visiting our website. There's a link in the chat. And if you're a KOHC member attending today who has requested CEU credits, I will have those out to you by next Friday, April 5th. If you have any questions about membership or CEUs, feel free to email me. I also put my email address in the chat. And as you know, there's a lot of work to be done to improve oral health in Kentucky, and our donors and sponsors are great support in moving this work forward. Again, we want to thank CareQuest for their support. If you'd like to learn more about becoming a sponsor or a donor for KOHC, you can visit our website and learn more there. I have a link in the chat for that as well. And I believe that is a wrap for our spring quarterly meeting. Thank you, everyone, for the really important discussion today. We're looking forward to working with you all more.